Watch as a human hand adjusts its angle and trajectory in midair to intercept a fast-moving object. It happens in a fraction of a second, requiring precise coordination from the upper limb. While the hand makes the catch, it relies on the joint situated midway up the arm. The primary functional purpose of the elbow is to position the hand in space. The elbow is a uniaxial hinge joint. This mechanical restriction to a single plane of motion is the basis for the structural complexity found within the limb. Anatomically, the elbow is defined as a compound synovial joint of the hinge type. To understand this mechanism, we will examine the joint's layers, from its osseous surfaces and capsule to its clinical failure points. Functional mobility in the arm requires these underlying structural constraints to remain stable. The foundation of this system consists of three osseous structures: the distal end of the humerus and the proximal ends of the radius and ulna. This diagram identifies the first primary articulation zone, the humero-ulnar joint. Here, the pulley-shaped trochlea of the humerus locks into the trochlear notch of the ulna. The second articulation is the humero-radial joint, where the capitulum meets the head of the radius. The third zone is the proximal radial ulnar joint, where the head of the radius meets the radial notch of the ulna. This radial ulna articulation is functionally associated with the elbow for rotation, rather than acting as a primary component of the hinge itself. The integration of these three separate articular surfaces creates the foundational compound architecture of the joint. All three articulating surfaces are enclosed within a single continuous synovial boundary. The capsular ligament defines this boundary, attaching to the lower humerus. This attachment ensures the capitulum, the trochlea, and the radial, coronoid, and olecranon fossae are all intracapsular. Osseous structures alone cannot maintain the hinge. The joint requires medial and lateral ligamentous restraints to remain uniaxial. The primary medial restraint is the ulnar collateral ligament, or UCL. This lateral view illustrates how the capsule and ligaments reinforce the joint. Medially, the triangular UCL provides necessary tension, attaching its apex to the humerus and its base to the ulna, with thick anterior and posterior bands. This medial restraint allows the joint to resist lateral deflection and maintain a specific flex and extend pathway. The lateral counterpart to this system is the radial collateral ligament. The radial collateral ligament is a fan-shaped band extending from the lateral epicondyle, as seen in this diagram. It integrates directly into the annular ligament. This ligament also serves as the physical origin for the supinator and the extensor carpi radialis brevis muscles. These muscles form part of the topography surrounding the structural limits up the joint. Anteriorly, the joint is bordered by the brachialis muscle, the median nerve, the brachial artery, and the biceps brachii tendon. Posteriorly, the relations are limited to the triceps brachii and the anconeus. This muscular topography wraps the stabilized hinge axis, defined by the collateral ligaments. The elbow joint is supplied by a network of nerves via local anastomoses. 4 specific nerves provide this supply: the ulnar, median, and radial nerves, and the musculocutaneous branch to the brachialis. Flexion is driven by the biceps brachii and the brachialis. Extension is driven by the triceps brachii. Rotational movements, such as pronation and supination, are governed by muscle groups acting on the associated radial-ulnar joint. These neural inputs coordinate opposing muscles to move the limb within its established mechanical limits. These mechanical constraints make certain structural failures predictable under repetitive stress. Because the ligaments anchor to small areas of bone, the epicondyles become focal points for injury. Stress at the lateral epicondyle leads to lateral epicondylitis, commonly known as tennis elbow. Stress at the medial epicondyle leads to golfer's elbow or medial epicondylitis. In children, a pulled elbow occurs when the radial head subluxates at the annular ligament interface. These pathologies are direct results of the joint's ligamentous and epicondylar design. This flowchart synthesizes the functional map of the elbow joint. The articular surfaces are held in place by the ligaments and the capsule. Once constrained, these structures are activated by innervated musculature to produce movement. The elbow is a constrained compound system. Its uniaxial stability provides the rigid foundation necessary for the shoulder and